Welcome to this PCR webinar about the remaining limitations of TAVI. So my name is Nicolas Dumontet. I'm interventional cardiologist in Toulouse, France. And my pleasure this afternoon is to share with session with Sonia Petronio with the University Hospital of Pisa. You're also interventional cardiologist, Sonia.
Yes.
Good afternoon.
Yes, hello.
And with Dan Blackman from the Leeds General Infirmary Hospital in the UK, and you're also interventional cardiologist.
Indeed,
Dan.
hello.
Yeah, good afternoon. So Dan and Sonia, when we prepared this session, we tried to think about what could be in 2018 the main limitations of a TAVI procedure. Of course, we know that now TAVI is a mature procedure, but we still have some drawbacks, some phases of the procedure or the outcomes that are unclear or some problems that are unsolved. And altogether, we found that there are maybe three chapters that could be developed in that sense. First one could be about the pacemaker issues, and we'll develop that later on. Second one could be about the stroke prevention and cerebral protection devices. And third one could be about leaflet valve thrombosis and valve durability. So what we do during the following minutes is first I will deal with the pacemaker chapter. But Dan, maybe you could say a few words about the stroke and cerebral protection device chapter.
Yes, so I think we chose stroke because I think we accept it's probably the most feared complication for our patients and something that we maybe haven't made as much progress as we have in other areas of TAVI. So we're going to focus on that and discuss whether there's anything we can do to prevent stroke, specifically the advent of embolic protection devices.
Okay, thank you. And Sonia, just a few words to introduce your chapter about leaflet valve thrombosis and valve durability.
Well, we are going to talk about thrombosis because it is a new and interesting subject that has a link generally on valve durability, and it's very important because now we deal with more and more TAVI, younger patients. We need to know, first of all, how much is important this thrombosis and how can we cope with it, and if the valve are really durable to be extended to younger patients.
Okay, so thank you. Very clear and very interesting program, hopefully. So let's now dive into the first chapter that is about the permanent pacemaker issue and issues we can still have in 2018 regarding this problem. So what we just would like to share with you, as you see, are data that will help us to review what is known about the pathophysiology and the main predictors of pacemaker implantation after TAVI. And most importantly, and we'll develop that, is also to try to understand how to stratify patients at risk of delayed high degree AV block after TAVI requiring permanent pacemaker implantation. So just briefly to introduce the subject and the topic, general information that we all know, but I think that are important to remind. What is the problem? What is it problem, and why is it a problem? Sorry, and why is it important? Because it's illustrated by this simple anatomical drawing that reminds us that our landing zone with our transcatheter heart valve is the vertebral basal annulus and the aortic roots that is illustrated on this slide. And you see in green the membranous septum when you have, anatomically speaking, the east bundle system that is just cruising. And you perfectly understand by seeing that why you can have a mechanical interaction between the device and this anatomical structure leading to some impairment in the atrioventricular conduction system. So what we have seen reviewing the literature, because we're implanting TAVI for years now, so there have been a lot of literature on that, and it has been grouped in a meta-analysis. And what we have learned and what we have seen is that we can individualize some patient-related factors that will be predictors for pacemaker implantation, like gender, male in some studies. You can individualize some ECG factors, RBB, the most powerful one, I think, and also some procedural factors. And we know that the balloon expandable valve provides less pacemaker rates than the self-expandable concept, and also that the implantation depth in the LVOT is also a strong predictor, and if we think about the anatomical consideration we've just discussed, it's totally understandable. Okay, so we know perfectly how to even individualize a patient that will be at risk of permanent pacemaker implantation. If we have a third-degree AV block during a procedure, of course, the patient will have an implantation. So to my opinion, in my current practice, it's not really an issue. But if I think about the remaining issues I have with pacemakers and TAVI, I think one of the most burning one and most difficult one would be to try to identify when a patient has had this TAVI with a good outcome, immediate procedural outcome, if he will have a probability or a risk to have a delayed high-degree AV block during the hospital follow-up that would require a pacemaker implantation. And this is, I think, to my opinion, the most difficult. And just to have your opinion on that, I would like to share with you and with all of our peers, our colleagues, this simple clinical case. You see, it was a patient I've treated months ago, and this is its baseline ECG just day one before TAVI. So I'm sure you would agree that it's a sinus rhythm. PR interval, as you see, is normal, and you have only an incomplete RBB at the baseline. So based on this ECG pattern and knowing that RBB can be a predictor of pacemaker, we've implanted a valve trying to have a very, very high position if possible. And it's a technical thing that we can influence. So we did it. Immediate outcome was good. And on day one post-TAVI, you see the ECG that was recorded, still normal PR interval, still small incomplete RBB, so everything was fine. And on day 3 post-TAVI, what appeared, as you see, is this prolonged PR interval, and now with a LBB that appeared. So I would like to know, and it would be really, really interesting to know how you would manage this kind of patient in your institution. So let's start with you, Sonia. What would you do in front of such a situation?
Well, it is an interesting patient because the position and the procedure was perfect. I mean, the valve was high, it was a self-expanding valve, but the changes of the ECG in the third day and although already the right bundle branch block since the beginning, it would take me to implant a new PM in this patient. I think I would not leave him with this kind of ECG. I would not wait further than 3 days. Definitely.
Okay, so let me just summarize it, because I think your position is interesting and very important. Because if we think about our current practice now when we implant pacemakers after TAVI, the strongest indication as per guidelines is to implant in case of high degree AV blocks, so third or second high degree AV block. But in that case, you consider that the patient is at really, really high risk of delayed high degree AV block, and then you would implant him at this day in a kind of prophylactic way, right? Or you would implant him right now?
Well, there's been a change.
Yeah.
First, it was a right bundle branch block.
Yeah.
Now there is an enlargement and left bundle branch block too.
Yeah, yeah.
And so even according to the guiding lines,
Yeah.
I would have the approval.
Yeah, you're right, and I think what you underline is that it's really, really important to pay a careful attention to daily analysis of ECG after TAVI, even though the procedure went well and you didn't have any third degree AV block, right?
Yes, I
Okay.
perfectly agree.
Dan, I would be also interested to see what would be your behavior, your management in your institution with such patient. I'm sure you already had such patient.
Yes, I mean, firstly, I completely agree with Sonia. I think, alternating right bundle and left bundle branch block is a standard indication for pacing even outside of the context of TAVI, and particularly with TAVI where we know right bundle confers such a high risk of events. I think the other question for me is the role of prophylactic pacing in right bundle branch block.
Yeah.
As you said at the beginning, right bundle branch block is the most powerful indicator of third degree AV block acutely after a TAVI.
Yeah.
But there's also now pretty strong registry data indicating that right bundle branch block, if left without a pacemaker, is associated with late mortality as well.
Yeah.
So even if this patient of yours hadn't developed a left bundle branch block, the data would suggest they are at increased risk of very late, maybe even months or up to a year, sudden death due to bradyarrhythmia.
Okay.
So in our institution, we have, up until relatively recently, paced right bundle branch block prophylactically before the TAVI procedure.
All patients with complete RBB?
All patients until fairly recently. What's led to a change, I think, is that, as you know, the rate of third-degree AV block has fallen. And that's partly because of new devices that have lower incidences of third-degree AV block. But even with the same devices, like the Sapien family, and particularly the core valve Evolute family, the pacemaker rate has fallen. So now we might look in those patients with pre-existing right bundle at choosing a device which will have a lower risk of AV block. But then I think, as you alluded to, it's absolutely essential to very diligently follow that patient after the procedure.
Yeah, and just coming back a few seconds on what you've underlined about the data we have regarding patients having a preliminary RBB. Are you saying that these data are supporting the fact that there is an excess of mortality, probably related to sudden death because of acute high-degree AV block during follow-up?
Yeah,
so for those who are not implanted, of course.
Yeah, so these are data from kind of multi-centre Canadian registry, which looked at late mortality, and specifically in patients with right bundle branch block. And what they found was that right bundle branch block was associated with an increased risk of late mortality compared to the absence of right bundle branch block. This is on discharge. But if they then divided those patients up into right bundle branch block with a pacemaker and right bundle branch block without a pacemaker, then the two curves diverge. So right bundle branch block with a pacemaker, no difference in late mortality, but without a pacemaker, a clear excess. So strongly suggesting that the reason for the excess of late mortality must be bradyarrhythmia they're not protected against from a pacemaker. So I think that's what we need to be aware of, not just the acute in-hospital risk, but also the risk after hospital discharge.
Okay, great. And so let me just you what was the outcome for this patient, but I think it won't be a big surprise for you. So just 2 days after, and we should have been maybe more cautious about the follow-up of this patient. But 2 days after, he had a third-degree AV block, and of course was implanted. But just coming back to this typical clinical case, maybe not as striking as this one, but about this issue of delayed acute high-degree AV block, I think still it's again maybe one of the most difficult issues we still have after TAVI, and it's related, of course, to early discharge and things like that. So I found it interesting just to support our experience and our practice to share with you this study. It was done by 3 Swiss centers 2 years ago, and in a series of approximately 1,000 patients treated by TAVI, they looked at the relationship between the need for permanent pacemaker implantation before hospital discharge and daily interpretation of the ECG. And just look the summary of their finding, because I think it's really, really useful. You see that, and they found that for patients that are in sinus rhythm without any conduction disturbances at the baseline, no telemetry required because 0% of pacemaker implantation. Exactly the same for patients in atrial fibrillation at the baseline without any enlargement of QRS or bradyarrhythmia. But for all the other patients, and especially for those having dynamic changes into ECG length, in QRS length, they found that there is a higher probability of high-degree AV block than requiring telemetry, because it could require permanent pacemaker implantation before discharge. So, Dan, can you make maybe a comment about that? And because you told us about the prophylactic pacemaker implantation, so do you consider in your practice that implanting a pacemaker after TAVI is an issue per se, per itself?
Absolutely, and I think that these data really help us, as you said, and one of the key things they impact on is our decision about fast-tracking patients. So, as you know, TAVI's become a much less invasive procedure, routinely performed under local anaesthesia, rapid mobilisation of patients, and invariably the main issue determining whether a patient is suitable for early discharge is whether there's conduction abnormality. So I think what these data tell me, that if I have a patient with the immediate post-TAVI 12-lead ECG who has sinus rhythm with normal PR interval and QRS duration, or AF with no bradycardia and a normal QRS, then you can stop telemetry, take the temporary wire out, and that patient is suitable for early discharge.
And this is very important data, I think.
Absolutely, but equally, and as your case shows, we've got to think about the other group of patients where we shouldn't be rushing them out of hospital, because if we do, we may be putting them at risk of events that could be dangerous. So in those other group of patients where we don't have those normal PR interval and QRS duration, then we need to look at ongoing telemetry, at least until the ECG has been stable for 48 hours.
Okay.
But what do you think about, if you look at the slide, it is only the 25% that you would discharge earlier and with a normal ECG. And what would you do of the other 75%? You're talking about prophylactic pacemaker.
Well, the prophylactic
pacemaker. Would you increase
pacemaker.
your percent?
Yes, the prophylactic pacemaker is controversial, and I said that for me that's exclusively for right bundle, and I think today with lower rates of AV block with the devices we have and the improvements in procedural technique that Nicola alluded to, I would reserve that for right bundle with other risk factors like a broad QRS, additional left axis deviation, first degree AV block. But as you say, we've got, I think from my recollection of the study, 25% of patients who have sinus rhythm with normal PR and QRS, and then there's another cohort of patients with AF and a normal QRS. So it's somewhat more than 25%. And those patients are eligible for immediate discontinuation of telemetry. But then there's the other group of patients where after 48 hours with a stable PR interval and QRS duration, we can plan to discharge the patients. And then the other group of patients where there's dynamic changes in the PR interval and QRS duration, then we have to think potentially about other approaches. And I think, Nicola, you mentioned to us some data from the Rotterdam group to add to these and give us a further steer on how to manage those patients.
Exactly, it's exactly that. And it helps us to refine the finding of a Swiss study. Just related again to that issue of pacemaker implantation, we had some data about long-term mortality and impact on mortality after pacemaker implantation. So what are your thoughts, Sonia, about that?
Well, this is why I was asking before about to Dan what he thought about prophylactic implantation, because I think that there are some studies describing a little bit of changes and not a very good outcome, a long-term outcome, when you put a pacemaker that perhaps after 50 days it is not more important for the patient. And if we think that we will implant TAVI to a younger patient and we enlarge all the population of TAVI, we have to think that sometimes these leads can cause to some infection. So having a lead in the heart is not as positive as we generally think. There are some cautious things that we have to take in consideration when we decide for a patient for a pacemaker.
Okay, but and look, you can have a brief look at this data. It's one of the controversial data you were talking about. I think this one illustrating the absence of a significant difference regarding survival or heart failure, whether you had a pacemaker implanted 30 days after TAVI or not. Okay, so I think a very, very interesting debate and question. Again, I would like to remind our peers and our colleagues not to forget to send us some questions at any time. Again, feel free, and I see we have some of them quite interesting. So maybe I will start with you, Dan, and with one of those questions. Does the patient risk to need a pacemaker implantation affect your choice of device?
It's a good question, because as you know, we've seen quite different rates of pacemaker implantation with the different devices, although I think we've seen with most of the devices the rates coming down. And for example, the gap that you referred to earlier between the Sapien family of valves and the core valve, now Evolut family of valve is closed, so they're quite similar. But we have some other valves like Lotus not currently available with much higher pacemaker rates. And now perhaps some devices with very low pacemaker rates starting to become available, like the Symetis Accurate Neo valve and the Centera, which are just coming along.
Do you consider for those valves that, for example, the concept of deployment from top to bottom plays a role in the interaction with the conduction tissue or not? maybe it's a speculation.
It is speculation, I think. I mean, that's not something it's hard to know. We haven't got any data suggesting
Yeah, of course,
that.
of course.
The data tell us it's more to do with depth and radial force in the LVOT.
Okay.
But to come back to your initial question, we have in my centre 3 valves, and we try to make a careful selection in each patient as to which is the best valve.
Okay.
The risk of AV block is not at the top of the list of our considerations,
Okay.
but it is one factor that we'd consider. And I think, as I was saying earlier, we had a patient this week with a partial right bundle branch block, so really quite similar to yours. And in that patient, where there were no other key factors driving us towards valve choice, we chose to use a device with a particularly low pacemaker rate, in this case the Accurate Neo, and sure enough, that patient has done pretty well, hasn't as yet, it's only 48 hours and we're monitoring carefully, developed any late AV block.
Okay, Sonia, maybe difficult question for you, and because we don't have any conclusive data, but just your expert opinion. We know that after pacemaker implantation, it seems that after 30 days, maybe more than 50% of the patients do not need anymore their pacemakers. So, is there a way to reduce that number? Do you see somehow a way to reduce that, or it's difficult?
Well, it is a difficult question
of course,
and a difficult answer. But I think that all the data that we have that confirm the fact that after 30 days you see a 50% around of patients that don't need any more pacemaker, probably is due to the fact that most of the studies are done without some common indication of implantation of the pacemaker. So probably this part of patient could be, at least some of them, patients that really didn't need a pacemaker. Mm-hmm. Some centers implant a pacemaker even only with left bundle bunch block, just to make sure to avoid long-term events, or to be able to discharge the patient. So I think that you should consider this 50%, but probably is not really true, the amount, if the population is well selected.
Okay. And maybe another very short question I will address in that particular patient. What kind of permanent pacemaker was implanted? So, and a more general answer coming from this question. What we usually do is implant a dual chamber pacemaker in patient in sinus rhythm, in patient in atrial fibrillation single chamber pacemaker, and in patients who already have a very depressed left ventricular ejection fraction, with no major contractile reserve, no major elevated gradients. So patients in whom we anticipate that they might still have a depressed LV function afterwards, then we implant a CRT device. So just to close this first chapter about the pacemaker, we saw that we have still, of course, an unresolved question about the long-term impact, for example, of implanting a pacemaker. But I think our main goal was to try to refine a kind of a strategy to follow up patients and to decide the ones who could be discharged early and the ones at risk for permanent pacemaker implantation. And I think it can simply be summarized. Let's keeping practical and simple. And coming from the data we've discussed, I think we can say that patients who have a normal ECG at baseline and no persistent conduction disturbances post-TAVI, these ones have no risk of delayed third-degree AV block, and they could be a candidate for early discharge. Patients who have stable ECG for at least 48 hours after TAVI, again, those ones, low risk of delayed third-degree AV block, almost none, and then candidate for early discharge. And opposite to that, patients with pre-existing conduction disturbances and persistent conduction disturbances changes during the follow-up, those patients would require probably careful monitoring. These are the ones where we haven't understood yet everything, and these are the ones that don't need an early discharge, and these are the ones that have to be followed up. Okay? You're fine with that. So
yes, fine.
Let's now move to the second part of the webinar. So Dan, can you introduce your chapter about stroke and cerebral protection device?
Indeed. So, as I said when we had the introduction, I think stroke for our patients remains the complication that they're most afraid of and want to avoid at all costs. But actually, we've probably not made very much progress in reducing the risk and preventing those episodes. So I'm going to introduce the stroke subject. We can have the slides for that with a case. So this is a real case that happened in our institution last year. 78-year-old patient, standard high-risk case, previous stroke, perhaps relevant. TAVI performed under local anaesthesia, which is our normal practice in Leeds, and a good valve result. But immediately after deployment of the valve, the anaesthetist who was administering the sedation, the patient was awake, said the patient had clearly changed, sudden onset of aphasia, clear-cut right hemiparesis.
Yeah, so you were happy to be on local anesthesia at that time, yeah?
Well, as you allude to, it meant we could make an immediate diagnosis and transfer the patient straight to CT, go on to perform CT angiography, and hopefully you can see here where the red arrow demonstrates is actually, in this case, a lump of calcium clearly visible in the left middle cerebral
artery. It's where you have put, for those who are not specialists in cerebral imaging, it's where you have put the red arrow, right?
The red arrow, and there's a white blob there.
It's a hyperdense image you have in the vessel, right?
Exactly, with reduced flow beyond that.
Okay.
Now, this patient underwent immediate neurovascular intervention, but unfortunately that was unsuccessful. Well, those techniques are mainly designed to remove thrombus, not hard calcific nodules like this. And this patient did badly. She survived, but she's dependent on 24-hour nursing care.
Okay.
So you can see what a catastrophic event this can be in an otherwise successful procedure, but ultimately clearly unsuccessful. And just to set the context to my other point about how little we've achieved, if we look at these data from the UK TAVI registry, you can see that on the left, when we look at mortality, it emphasises how well we've done improving outcomes with TAVI. Yeah. We referred to the improvements in pacemaker rate, but mortality, probably the ultimate hard endpoint. We can see that over the last 6 years in the UK, it's fallen quite dramatically. But when we look at stroke on the right-hand side, it's bobbed up and down, but essentially we've made no impact.
It's true that it's striking. It's the only complication that did not reduce with experience.
Exactly, and I think you've shown the same thing in the France 2 registry.
Yeah, exactly. Yeah.
So I think the questions I wanted to focus on today, Nicola, are the true risk of stroke. Those data suggest that it's around 2%. Is that right? Can we identify patients? Could we have seen that our patient from Leeds was high risk? And could we, more importantly, if we had identified a high-risk patient, have done something about it? And particularly, we're going to discuss the role of cerebral embolic protection. So talking about the true incidence of cerebrovascular events, when we look at physician-reported data like France 2, UK TAVI, we often see rates of about 2%. Yeah. But here I've shown some data from the control arms of cerebral protection studies and from the Reprise 2 registry. And these are studies which use neurologists to examine patients routinely after the TAVI procedure. And you can see that when we do that, we see clinical stroke rates. So these are not subclinical, these are clinical stroke rates, which are far higher, around the 10%, sometimes even 15, up to 27%.
I think
in Mistral C.
Let's clarify that it's only dealing about the person who is assessing the stroke, right? Yes. Because when it's the cardiologist who is not a specialist, neurologist specialist, the rate is low because there are probably a lot of underreported events.
And that's exactly right.
And when it's a neurologist, then he's more accurate in detecting the strokes. That's your point.
That's exactly right. So we're underestimating the clinical stroke rate.
Yeah. But we know, correct me if I'm wrong, yeah? But we know that we have some previous study with MRI systematically done after TAVI cases, when we saw, some variations according to studies, but stroke rates or silent ischemic events documented by MRI ranging to 70 to 80%, right?
Absolutely, yeah. So cerebral embolization is almost universal. And when we come on to discuss cerebral embolic protection, we've seen the same things, that there's almost always, I think 98% of cases, some debris is trapped in the embolic protection device. But I guess what we perhaps don't know is the clinical significance of those subclinical cerebral emboli that we see on MRI. Yeah. Sonia, what's your view on that?
I was just asking you, because we are concentrating on clinical, which we understand the neurologist needs to tell us something, but then we concentrate on imaging. And do you really think that the images that we caught just after TAVI or a week after TAVI, as they are described in literature, are the ones that really deal to some irreversible event in our brain? or we think that it could change with time. There are some old experience that neurologists taught us when they were looking at carotid stenosis and carotid protections, that they were looking that these events described with nuclear resonance, they change after a few months. They disappear, like not all of them, of course. So probably we underestimate the clinical, but we probably estimate the imaging results that we have. I don't know, this is a question.
Yeah, in other words, you're questioning the clinical relevance of those silent ischemic events seen by MRI, right?
Let's say I probably am afraid that we are overestimating. Probably they are, but not all of them are irreversible. This is my point.
Then just before we proceed to the discussion and the rest of the discussion, I think that we have now a question from our peers and our colleague that it is worth answering now before to talk about other subjects. That is whether TAVI under general or local anesthesia is relevant for stroke early identification.
Well, it's a good question, and I think the answer is fairly clear for me.
Of course.
That with local anaesthesia, especially, and people talk about TAVI under sedation, and actually we're moving away from sedation really in many centres towards really just local anaesthesia and minimisation of sedation, which I think we understand the patient tolerates the procedure better, but it enables us to identify major complications earlier, not just stroke, but certainly stroke. And that's something we've clearly seen in our centre. We used to identify strokes even not just a couple of hours after general anaesthesia, because you never knew whether the patient was still recovering from the anaesthetic or whether there was actually a neurological problem. With local anaesthesia, it's immediately obvious, and the patient can go straight from the cath lab to the neuroradiology lab, where, although in our case it was unsuccessful, neurovascular intervention can save the day.
Yeah, I have exactly the same case to share with you. We had one patient who had a very major stroke. At the time we did TAVI case under general anesthesia, and we did the diagnosis 6 hours after, because exactly for the same reason you told. The patient recovered from anesthesia, he was transferred in the ICU and then in another room, and before the nurses warned the physician that there was something wrong, it took 6 hours. So I'm advocating for local anesthesia, mainly also for that part. But let's just leave this discussion. And sorry, I interrupted you. So I leave you come back to your point and your discussion.
No, not at all. I think the first thing we wanted to do today was just to highlight the importance of stroke, not just disabling stroke, but the greater frequency of clinical stroke. But I think what we really want to do as clinicians is try and prevent stroke. And that leads us on to the discussion of cerebral embolic protection. We know from registry data that about 50% of strokes in the year after TAVI are in the first 48 hours. And therefore we believe that they're procedural events and almost certainly related to cerebral embolization. And that's where the issue of cerebral embolic protection comes in. If we can prevent debris going up to the brain, hopefully we can prevent these strokes. So as you know, we've had one major trial. There's been a number of smaller trials, but the biggest trial to date was the Sentinel trial, which is the Claret Sentinel device, which protects the innominate artery and the left common carotid.
So just briefly, before you keep on explaining, the Sentinel with the Claret device, the Claret is the two basket protection device, right? Huh?
That's right. So it's a right radial 6 French approach, and the proximal filter deployed in the innominate, and the distal filter in the left common carotid, which of course leaves the left subclavian and left vertebral artery unprotected.
So it protects 3 of the 4 main cerebral arteries, right?
Exactly, 3 of the 4, but there's some discussion about how that might actually amount to 90% of cerebral blood flow when you factor in it's the circle of Willis and the effect that can have. So maybe the protection is closer to 90% than 75%.
Okay.
So the Sentinel trial, to come back to that, this was presented towards the end of last year, and this is the primary efficacy endpoint. And you can see from the p-value that I've shown there that on the face of it, this is disappointing.
Yeah.
The primary endpoint was new lesion volume on MRI, a surrogate endpoint because of the relatively small size of the trial, and a 42% reduction, but nowhere near clinically significant. So if we stick to our strict interpretation of trials, we call this a negative trial.
Yeah.
But if we look further, and particularly if we look at the clinical endpoints of stroke, and we look at peri-procedural stroke, you can see from this slide on the right-hand side.
Secondary endpoints from the same trial.
Same trial, but the investigators, not believing they could power a trial to demonstrate a difference in clinical stroke, focused for the primary endpoint on the surrogate of new MRI lesions. But actually, when they did the stroke analysis, they saw what appeared to be a much more impressive change. So we see here an over 60% reduction in the incidence of clinical stroke within 72 hours. So a trial that's really hard for the clinician, for us jobbing interventional cardiologists to interpret, and that's why I'd like to ask you, and first maybe Sonia, how do you interpret these data? Sonia, you've seen this trial, and you've probably seen the meta-analyses with the other smaller studies. What are you doing in PISA with cerebral protection? Are you using it?
Well, first of all, let's say that there is not only this kind of protection. Now we have different kinds of protection. We have experience with different kinds. This, which is more the filter protection, the other as more deflectors protection. Well, we had some positive and negative first experience. One was of a patient that we protected with the same filters as this trial.
With a clarity in the trial?
Yes, but because it had an ulcer, a very complicated ulcer on the arch of the aorta, and we thought that that was the best protection we could have. It was in local anesthesia, and after just deploying the valve, it had a stroke, an evidential stroke, and CT demonstrated a stroke through the vertebral. So, how to say, in this patient, for instance, we didn't have a success because we didn't protect all the important arteries. So what at the end we do, we try to consider patient by patient if there is a risk in that patient, and we probably consider that perhaps protecting all the important vessel like a deflector could be probably more effective, but we don't know because we don't use these protection for each patient. So it's more tailored than everything. Yes, we select a lot.
And Nicolau, what do you use? Your approach the same? And if you do select, how do you do it? Are there any risk factors we can use to guide us?
So briefly to come back to your question, well, my personal opinion at the moment is that the data you've shown are promising, hypothesis generating, but negative to date. But given the pathophysiology of those strokes, I still believe in the probably a protective effect of those devices, and I hope probably this will be demonstrated by the science. So at the moment, what we do is we have a limited number of we work with a dual basket claret device. We have a limited number of devices that we buy because it's not reimbursed in France. And then we try to select the patient, to our opinion, that are at higher risk for periprocedural stroke. So mainly the ones with a previous history of stroke related to vascular atheroma, not to AFib or things like that, but to vascular atheroma. Secondly, patient with bicuspid valve or some particular anatomical features at high risk for technical difficulty when we will have to recapture the valve several times, to predilate several times, and things like that. I think about also, even though it's a niche, to the MAC patient. When we treat a MAC, sometimes we have a lot of frictions in the mitral annular calcification with the device, and then we can have a lot of emboli with that. And these are, I think, the main criteria selection we apply. From a technical point of view, when we decide to use the claret device, we just pay a little bit more attention during the CT analysis to the innominated artery, the anatomy of the aortic arch, because relative contraindication is a bovine arch with an unfavorable curvature of the vessels. And from a technical point of view, after a very short learning curve, it's a device that is really, really easy to insert and to use. Of course, you need to have a suitable right radial artery for a 6 French sheath. But to my opinion, it's really a simple device, and that's the way we use it in Toulouse.
Yeah. Well, I mean, I think I agree with you. It's difficult with the data to justify using it in every patient, although that is done in some centres. In Leeds, we select patients on the basis of increased risk, mainly on the presence of a previous stroke, which has been a consistent risk factor in the randomised trials and registry data. But I think the other point for me that's important with these cerebral embolic protection devices is ease of use, safety, and how much time do they add to the procedure.
Exactly.
And I'm with you. I think the nice thing about the Claret Sentinel is it's an easy device to use. It doesn't add too much time to the procedure. Yeah. And what the Sentinel trial showed us is that the risk of complications is very small. They had one vascular complication, which was a relatively minor problem out of over 240 patients. And that's why it's led to the analogy of the seatbelt. You don't need it most of the time, but why wouldn't you have the seatbelt on? Because it could save your life.
And just a very short answer to that question before we move on, Daniel. Do you think that all the different devices, so mainly the baskets and the deflectors, are the same level, have the same level of protection to date, or we don't have enough data to conclude on that?
Yeah, I don't think we have enough data. I mean, you know, the deflectors, so there's the umbrella device and the TriGuard device, which are the main deflectors. They have been used in small trials, and those trials were quite impressive. So particularly if we take the TriGuard, if the device was in place throughout the procedure protecting all three vessels, then it seemed to have a big impact. However, that was something of an if, because it was a more technically demanding device to use. So I think that's a question we don't know, we can't really answer at the moment.
Okay, thank you.
Okay, well, let's sum up. We had a good discussion about stroke, and I think what we've agreed, firstly, clearly it can be a catastrophic complication, and most of our patients they'll often say to you, I just hope I don't have a stroke. And we've discussed how the true incidence and the cost of cerebrovascular events is almost certainly underestimated. And finally, we spent some time discussing cerebral protection, I think is the pivotal issue at the moment, and how the data suggests that it may reduce acute stroke, but current data are inconclusive.
And just before to close this chapter, for both of you, maybe a quite not trivial but provocative question, but not related to science, but as physician also we know the outcomes of the devices we use in everyday practice. So just imagine you would have to do a TAVI to your father or your mother in the next 10 years. Would you use a cerebral protection device? I can give my answer short. I say yes. What is your opinion?
For me, it's simple. Yeah, if money was no object, I would use it in every patient, and I'd certainly want it in my family member.
Okay, Sonia?
Well, I'm a little bit more naughty to my parents. I would say that I would look exactly the comorbidities of my father before sort of trying to use at least these, at the moment, these devices. Who knows in the future? Okay,
so excellent. And I think now we can move on to the third topic we had scheduled, that was about valve thrombosis and durability. And maybe I would like to invite you, Sonia, to give a few words about this chapter.
Oh, thank you, Nika. Now, valve thrombosis, it's a new subject in some way, even if we know that even surgical valves have thrombosis in their leaflets. And in some way it is really strictly connected to the concept of if these TAVI valves are durable or not. Mm-hmm. So the fact that there's been a lot of literature in the last year saying that there are percent of leaflets thickening, leaflets with reduced movement, and in some of the patient an increase of gradient, caught a little bit of caution on this subject. So the importance of thrombosis came up really recently, but to add the importance is important to say that, as you see in this picture here, you see that to define exactly a valve thrombosis, you have to have a good imaging. Yeah. And this imaging is not echo, which is exactly the one we use to follow up our patients, but it's CT, and it's not a normal CT, but it's a high definition 4D CT, which is mainly not acceptable for all TAVI centers.
Yeah, it's
and
not the
highly
routine.
cost
It's not the
up.
routine CT that we do for preoperatively. It's not the same protocol.
It's completely different.
Exactly.
So, and this is very important. So the information we have is from studies that have looked in registries and trials, patient, and for instance, these imaging come from a famous study published in Lancet in 2017, where there was even a comparison between surgical valves and TAVI valves. And there was quite a few percent of patients with these imaging, but they were all subclinical. And those that had an increase of gradient, was important that they improved with the anticoagulation therapy, but there was, for instance, no relation with stroke, which is another important thing to say, because thrombi, you think of thrombi and you think about stroke in the same moment. So for this reason, I think that is really a debate subject. And I came with you with this story, this very short story of this case, of a female of 88 years old. She had a TAVI implanted in 2014. At the beginning, the main gradient was 10 after TAVI, and then slowly, in the next 3 years, increased to 18 and remained 18 millimeters of mercury until 2017, until now, I would say. So we had to decide if to treat and how to treat this imaging. You can see these black imaging very close to the valve.
Yeah, it's the hypodense image you have inside the frame, yeah?
Exactly.
Okay.
And so we really had big consideration of this old lady, and we decided to don't treat the patient with anticoagulation and leave her with her as a treatment. So what, Nicholas, what would you have done with this patient?
Yeah, it's always difficult, it's a trade-off, of course, but I think in such situation, 88-year-old woman, only a mild gradient impairment, probably without clinical consequence, right?
Yes.
Yeah. Only a finding with CT. I think I would have done the same than you, but I've seen the data regarding the study you detailed previously, of course, and every one of us has read this important paper. But what is difficult for me when I try to extrapolate this data to my everyday practice is that from those results, do you do routinely, for example, CT after TAVI to all of your patients?
Absolutely not.
No.
Absolutely
No.
not. We don't.
Yeah.
I think that as it has been stated even recently, the valves should be followed with echo evaluation every year, like the biological surgical valve. This is exactly what you should do.
Okay.
We did the CT because it was a little increase of the gradient, so we wanted to carefully look, probably because nowadays everybody is looking on thickening of leaflets and increasing of gradient, just because we are a little bit aware. But this doesn't mean that this has to be treated or that it can increase. And it's generally something that happens in the first 3 months of observation of the patient, not long term. If there's something happens, it generally is stated in the first 180 days, I would say. This is what at least is described. What do you think, Dan?
Yeah, would the British treat it differently?
I think in this case, I'd agree with you that anticoagulating an 88-year-old lady who's got a high bleeding risk is difficult to justify in the absence either of any symptoms or a significant increase in the gradient. And I think, we've already discussed some key points. I think it is difficult sometimes to see these, and if your radiologists or your cardiac radiologists are not clued up with the protocols required, then you may miss this. So in Leeds, what we do is if we see a patient with an increase in gradient, whether asymptomatic or not, we go looking for leaflet thrombosis. If we don't see it, then we would still consider, if it's a significantly elevated gradient, a trial of anticoagulation. And indeed, through that technique, we've seen patients whose gradient has gone up and has come back down again with anticoagulation. But we've got to think about bleeding as well. We've recently seen data, not in the TAVI arena, but in patients with embolic stroke who are randomized to aspirin or rivaroxaban. And the trial was stopped early because not only was there no benefit, but there was an important excess of bleeding, in the rivaroxaban group.
Overall bleeding or intracranial bleeding, or it was overall bleeding?
Overall bleeding,
okay.
Yes, overall bleeding.
Okay.
Well,
So
this is very important because, I mean, there are some evidence, like the study we were talking about, that there is a decrease of the gradient and of the thickness of the leaflets if you treat these patients with anticoagulation versus antiplatelet therapy, which is a decrease of more than the 10% in compare the two groups, which makes us think about it. But indeed, we should wait at least the oncoming trials, which are focusing on rivaroxaban or other a new anticoagulation therapy, to decide if or not treat these patients with this kind of therapy.
So it's really interesting, Sonia, because exactly at the time you're describing that, we have two different questions directly related to that. So I will cite both, and you will be able maybe to give us a short answer on both. First is, should we treat asymptomatic thrombosis discovered on CT? So you partially answered, but maybe you will develop a little bit. And second, what in kind of leaflet thrombosis, what kind of anticoagulation of treatment is given? Is it a new oral anticoagulant agent? Is it dual antiplatelet therapy? Is it VKA? So just a short statement, of course. But
well, in part we have already discussed this and answered. But I would say that if there is a gradient, we should treat it. If there is not a gradient, and if the evidence is very big, perhaps we can think about it. Otherwise, I would not treat it.
Okay.
In respect to the kind of therapy, now most of the centers stick to warfarin therapy because it's the one that we use in generally either with atrial fibrillation or not.
Yeah.
But otherwise, we really should wait the results of the trials. I think that otherwise we sort of test our patients. Don't you think so?
No, I'm going to disagree with you, Sonia. I think not for the first time. No, I think we would use a direct oral anticoagulant in patients with valve thrombosis, and we have some data here from the slide on the screen showing that it seemed to be equally protective. Yeah. So these are data where patients were already taking anticoagulation for atrial fibrillation or another indication, but it seemed to show that warfarin and direct oral anticoagulants were associated with an equally low incidence of valve thrombosis. So, and I think there are other very significant advantages, particularly in older and comorbid patients.
So let's say I can agree.
I persuaded you. That was quick.
Daniel, just to come to your point and maybe to clarify that, are you mentioning that because in fact you're extrapolating the benefit of a new oral anticoagulation that you know from the AFib study to this subset of TAVI population that is elderly patient, most of the time high risk of bleeding, and then you anticipate that you would have the same benefit than in the AFib trials. That's right?
I think it's harder to extrapolate the benefit.
Yeah, of course.
And in terms of efficacy, I guess we're more using these data from the leaflet thrombosis registry studies.
Okay, so it's an efficacy issue rather than a safety issue in your mind?
I think it's both. My point is that it's hard to extrapolate the efficacy, but I think we have these data to point towards equivalent efficacy. But I think it's reasonable to extrapolate the safety. That should be, there's no reason why in a TAVI patient the reduced bleeding risk seen, particularly with lower dose or some of the direct oral anticoagulants, it should be exactly the same in TAVI patients as atrial fibrillation patients.
Well, Dan, this is the only thing why I have a concern, because the age of this patient is still very high.
Yeah.
So the safety is something that is still for me a question mark, even if I understand and agree for the other.
No, I agree, and that's, as we discussed, I don't think any of us would have treated your patient with asymptomatic leaflet thrombosis. And at the moment, we're only using anticoagulation for treatment of patients with symptoms or high gradient. And I guess, as you said, what the trials are hopefully going to tell us is, can oral anticoagulation prevent leaflet thrombosis?
Okay, and Sonia, so the next question that is coming after this first debate is, In your mind or in the data we have, is there any relationship between those kind of left thrombosis and valve structural degeneration?
This is a good point, because I think that they are very, very connected in at least in what we are looking for. For instance, in this slide, you can see, first of all, that this is a meta-analysis where they looked if there was a relation between the clinical events of the patient and the leaflet motion, and they have found a strict relation, stroke and all other cerebral events. And another important is that the reduced motion for a certain percent can bring you to what is defined a structural valve degeneration.
Okay.
Because we have to think that if we talk about thrombosis for definition, it is not an irreversible degeneration. So as we said before, we can treat it and we can resolve the situation.
Yeah.
So if we look at thrombosis, we don't have to look as if it was a reversible event.
Yeah.
But we know now that from these studies that these events can lead to a structural degeneration, which is irreversible.
And coming to this definition of structural degeneration, I know that you were part of a task force about that in the context of ESC. So can you give us a little bit more insights on that? Yeah.
Well, first of all, in literature has been observed that there is a relation between what we observe even in endocarditis than in together with thrombosis. But the importance of is that in all literature, even in surgical details, we don't have the homogeneous definitions of what we consider structural degeneration.
Yeah, because for surgery, it's just freedom from reintervention, right?
Well, no, They really consider that as one of the structural degeneration, but that really should be considered a failure of the valve.
Yeah.
Because there are two different events that we have to consider. One is, like we can see in this slide, it's a structural valve deterioration, which means something wrong with the leaflets, with the struts, not with what we have performed during the procedure, but with the structure of the valve. Instead, the failure is something to deal with the patient. So with the clinical, it's a clinical endpoint, so with the outcome of the patient at long-term follow-up. So there are two different things, and we needed to define this. So we were talking about the task force. Yes, there was a task force of the European Interventional Society, of the European Society of Cardiology, and of surgeon, because, as I said before, there's not a definition both either for surgical valve than for TAVI valves. Now we try to homogenize and made a complete standardization of these definitions. And what is even important is to define when to talk about degeneration, when to talk about clinical outcome, because this makes a real difference.
And this definition is quite new. So do we have yet in the literature some data that have applied those kind of definitions?
Well, it's quite new. It has nearly, let's say, 1 year, because it was published just together with the guiding lines for valve heart disease. And yes, we have exactly one important trial, that was the Notion trial, that in 5 years follow-up had applied the definitions and look to a structural valve degeneration. You can see here there are two curves, and the Notion was a small trial, but a randomized trial between TAVI and surgical valves. And you can see here that there is a difference, a significant difference in valve degeneration. This means that the surgical valve had a higher percent of moderate hemodynamic degenerations, while TAVI didn't. And they were quite similar for the severe hemodynamic. And this explains that in the same trial, the failure of the valve, this means the outcome of the patient, were similar. So this means that you have to distinguish the two to understand exactly the phenomenon of these valves. But of course, this was only a 5 years follow-up.
Sonia, yes, that's the
point.
That's one of the points. I think we may have some surgeons in the audience, and these data are clearly encouraging for TAVI. I think the difference here, driven a lot by patient prosthesis mismatch, which obviously feeds into the definition on gradients. But the surgeon watching, I'm sure, as well as the interventionist, would say, well, 5 years is fine, but what about 10 years and 15 years? And at the moment, we've seen some data, including from the UK, that we presented last year at TCT, which looks encouraging with the low instance of structural valve degeneration, even out to 7, 8, 9, and occasionally 10 years. But it's small numbers of patients. So I think we're obviously looking for more data for longer term.
You're perfectly right. I mean, and now in literature we have only the follow-up of the main trials or the big registry that can take you up to 7 years, not more than that. Like the Italian registry, for instance, that we're following with 7 years, or the partner trial that was equally 5 years. But now what is the feeling is we want to know what's coming, and it's too late to do a prospective trial. So what we have decided in the European Intervention Society is to put up a registry with all the European centers that have begun very early in the years, around 2007, 2010, to have a snapshot of patients that are alive, still alive, and to look their valves with the echo data and to see how these valves look at 7, 8, 10, and 11 years, which could be an important information. Though I think that if we pass the 5 years now, we can say that we've passed the highest mountain. We will have to pass lower hills now. Don't you think so?
Well, I mean, I think surgical data have often shown 5 years is okay with all the valves, but some of them we start to see problems between 5 and 10, and others are still working well in the vast majority from 10 to 15. So I think for me, I'm looking for 10 years. I think if we can get to 10 years and tell the patients there's a high chance, then that could be a game changer in moving into intermediate and low risk patients.
Yes, so I think this is the point. We will be able to move really at low risk patients if we know exactly all the 3 subjects that we have touched, but especially durability. I perfectly agree with you. We can sum up.
Thank you very much, Sonia. Can you make maybe a small summary of the main learning points of this chapter about thrombosis and durability?
Yes, of course. Well, I can say that valve thrombosis, first of all, can be reversible, and this is very important to understand, but sometimes can lead to a structural degeneration. And then that to treat, to decide to treat valve thrombosis, well, we need to evaluate the role of the ongoing trial. Otherwise, probably we are not able to decide for all the treatment for all the patients, definitely.
Okay, so thank you very much, Sonia. Thank you, Dan. I think it's time to close in this webinar on the remaining limitations of TAVI. I hope you found it useful. Of course, it will be available to be viewed offline on PCR Online. Last, of course, on behalf of you, I would like to thank the PCR organization for their support in preparing this webinar. I would like also to support the Boston Scientific Society for supporting this independent educational program, and all the best from the 3 of us. Goodbye.
Thank you. Goodbye.
Bye, everyone.